and welcome to yet another episode of Guest Room. This is me, Anjali, here with you. Today we have a special guest. She is an MSK radiologist and sports physician at Oxford University Hospitals and St. Luke's Radiology, Oxford. Let us welcome Dr. Gina Allen to the show. Welcome, madam. So, before going deeper into your subject, we would like to know more about your early education and career life.
Well, I grew up in Bristol and then I went to university to do medicine in Southampton, which is in the south of the UK.
Okay.
And then my early life in medicine, I decided to become a family doctor, a general practitioner, and I trained in Lincolnshire. Then decided to join the military, and so I did my military training and I became a physician in the military, and I did a spell in various countries but went to the Gulf during the first Gulf War. And then when I came back from the Gulf, I had to make a decision on my main career path. And at the time, there were no opportunities in pure medicine, and I was thinking of rheumatology, but also radiology was a very big pull because as a woman, there were lots of opportunities, but it lent itself to having a fairly good career pathway, being able to perhaps have a family as well as having a career. So that's perhaps why I was initially attracted to it. And there was a good structure in the Royal Air Force, which is the service that I belong to pursue that career. So that's why I initially chose radiology.
So how and when did you find your interest in the area of radiology and sports imaging? Well, I started my training in London, and then because of family I moved to Oxford, and at that point I worked in David Wilson, my now husband's department, and as part of my training, and got very interested in musculoskeletal and very interested in ultrasound. So it seemed to combine a good balance of not only an interesting subject, but because I like people and I like interacting with people, ultrasound has allowed me to have that contact with people. So I went then from Oxford to, I did some of my training in Wales, and then came back to Oxford to do a fellowship in musculoskeletal, which is when I became fully fledged in lots of imaging modalities, so CT, MRI, X-ray, ultrasound, and some of the newer techniques. Okay. As your area is MSK, could you tell us more about MSK and its imaging? Well, MSK is, it encompasses all bits of the body to do with the tendons, the joints, muscles, so all the soft tissue that we use to move in our daily lives. And the imaging, well, every imaging that's used for every other part of the body is also used in MSK. So we use X-ray to look for bone predominantly, but then we're using CT and MRI, ultrasound, and then some of the newer technologies, including nuclear medicine. So nuclear medicine now is being used, perhaps not in its pure form so much, but we're now combining it. So we're combining technologies to advance either diagnostics, but also guiding injections and using some of these techniques to advance in MSK. Okay. So what's it like having an ultrasound? Could you tell us more about it? Well, ultrasound is a very patient-friendly technique because you're not using ionizing radiation, it's using sound waves, and you use gel to make contact between the probe that produces the images and the machine and the skin. So the main discomfort really is probably when the gel initially goes onto the body, it's a bit sticky, and if you haven't got it very warm, then it can be a little bit cold, which for musculoskeletal we do tend to use cooler gel because we like it nice and thick to be able to get the imaging away from joints and away from bones. And then you just move the probe across the area that you're interested in, setting up the machine as you go along and using different parameters on the machine, and then the machine forms an image and then we're able to give some diagnostics.
we're also able to use that to guide injections. So at the same time as that diagnostic examination, we might then proceed and perhaps perform an injection into a joint or into a soft tissue area such as a tendon. But because it's all done in one time, I think that really lends itself to being very user-friendly, very patient-friendly.
Mm-hmm. Could you tell us more about fluoroscopy? How is it done?
Well, fluoroscopy is a technique which uses continuous X-ray. Mm-hmm. So it's very useful for some areas of musculoskeletal. It's still used a lot for guiding injections into joints, for example. Mm-hmm. It's used not just by radiologists but also by surgeons to make sure that they've put the prosthesis in correctly, because they can, at the time of operation, because the equipment is mobile, they can actually look at the prosthesis and look at it in two views. So they can get like an X-ray appearance, mm-hmm. But they can angle it in many different directions, whereas an X-ray you are really, you're confined to using it in perhaps one area than another area. You can't move it around the patient. Mm-hmm. The big disadvantage with it is the radiation dose is high. So people are trying these days, I think worldwide, trying to reduce our radiation load. Mm-hmm. So it is very useful for some things, but certainly in UK practice now, I think more and more joint injections are now being done under ultrasound. So although in my practice I will still use it, for example, sometimes I'm using it for wrist mm-hmm. injections, and we do some injections before we do MRI. So this is now a diagnostic procedure. We're adding extra benefit to outlining the joints and looking for small areas of abnormality on the MRI. So we might inject a contrast material, so something that shows us that detail. Mm-hmm. And for wrists, I still use fluoroscopy, because I find I get the detail from the X-ray image as well as the MRI. Mm-hmm. But many other joints, I would say, I've now swapped to ultrasound, okay, because then I'm decreasing the radiation burden mm-hmm. to the patient.
Yeah. And what is the role of MRI in MSK?
Oh, MRI has a very big role. Mm-hmm. It does give us a very good overview of an area. So we're using it for soft tissue when we're not really sure what the diagnosis is, or maybe the area of abnormality is a very large area. Knees, for example, MRI is still probably the main area that we use. Mm-hmm. MRI and lumbar spine or spine imaging. Where it gives us more detail is perhaps in bone. So anything where the X-ray doesn't really give us the answer, we want to know exactly how big a fracture is or how big an area of tumour is. It gives us very much more detail, and it shows us that in a different way to an X-ray procedure. MRI, when available, was an extremely useful tool in musculoskeletal.
Mm-hmm. Could you tell us more about sports imaging?
Sports imaging is just really a small area of musculoskeletal imaging. So you're looking at abnormalities that affect not just elite sports people, but the general population, anyone who does sport. So, you know, your cricketer, your tennis player, they might be what we call a weekend player, so they're mm-hmm. not necessarily playing at a very high level, mm-hmm. but they go and they play their game and then they get injured. And what they're looking for is they're looking for a diagnosis, they're looking for a solution to get back to what they enjoy doing. Mm-hmm. And so these patients come along, usually with a very specific story, which is often the key in most of these problems, you know, mm-hmm. the story behind the injury or the problem that they're having. And then we use the examination of the patient to guide us into what imaging is the most relevant. Mm-hmm. So hopefully, as with most areas of medicine, we're trying to optimise the imaging that we're performing on the patient mm-hmm. to give them a treatment plan and tell them what's going to happen. Are they going to be able to get back to their sport, or are they indeed not going to be able to get back to their sport? Uh-huh.
What are the latest advancements in the area of CT and MRI?
CT, their main area, I think, for musculoskeletal is probably its fusion with other technology. Interestingly, CT scanners have become more and more advanced, and so now we talk about, you know, CTs doing many more images for a sort of slice of radiation. But that hasn't advanced musculoskeletal imaging that much, because there's only so much you can get out of a bone, which is what we're really interrogating with CT. But where it's become extremely useful is both linking those images with radionuclide images, using what we call positron emission tomography or PET scanning. So there are CT PET machines now, so we can see not only the CT image, but we can also see on the radionuclide image areas of abnormality, and we can cross-reference the two. And then some newer technology with ultrasound, we're now using CT, and we're feeding the information from the CT into the ultrasound machine, and we're using the bony landmarks from the CT with the soft tissue definition of the ultrasound, linking the two and making some image-guided injections safer. So, for example, some of the spine injections are now feasible under ultrasound because of the added link with CT, or indeed, if we're injecting a joint that's really difficult to see with ultrasound, we can use the bony landmarks and the soft tissue landmarks together with the technology, and we can then achieve an ultrasound-guided injection. MRI, there are, again, they're positron emission tomography scanners that are linking with MRI, so that's a very new development. And they're linking the two technologies, so you're seeing the abnormality on the MRI and then also on the radionucleotide scan. Other things in MRI for musculoskeletal, I would say that people are still trying to weight images, so they're altering the parameters on the imaging to try and see perhaps small areas of cartilage abnormalities. So in arthritis, we know that when we see arthritis on an X-ray, a lot of damage has been done. So with modern imaging, what we'd love to be able to do is see when somebody's at their very first point of getting joint wear. So the cartilage is beginning to break down, and how much of the cartilage, and then on the back of that, there are advancements in giving injections that might slow down that change in the cartilage. So people are trying to chase that. And then the other area, I think, which is very exciting, is people are weighting images to look at nerve fibres and tendon fibres along their length. So you might be able to pick up abnormality within that structure, which on just a normal MRI you couldn't see. But because you can see the whole structure, the whole length of that structure, you might be able to detect a small area which is causing the patient's problem.
So could you tell us more about tendons and joint therapies then?
Well, the mainstay, I think, for certainly joints is still steroid. A lot of steroid is injected, and it's because it works. You know, it's got a very good track record. Most people tolerate it without major problems, and when we're doing steroid injections, we do indeed look at patients' other drugs and, you know, what other problems they have, but very few patients it's a complete contraindication to. Why it works is we think there's an inflammatory process that happens with arthritis, so we're using it in a lot of arthritis patients, and it's very good in the initial phases. So it's a good pain reliever, and it might mean that they don't need to take daily painkillers for their problem. Very exciting now, there are a number of new drugs that are coming on the market that we're now trying to assess that might give us longer term treatments, so it might allow us only to do an injection, say, every 1 or 2 years rather than every few months. And those are the things I think that are in development. One of them is called sodium hyaluronate, and we're not really sure why it works. What we know is it's a factor of the normal lubricant that joints produce. So whether it's just enhancing that lubricant, There seems to be an anti-inflammatory element to it. There seems to be possibility it's making the natural joint produce more of that same substance. I don't think anyone really knows, but it does work in quite a number of patients. So that's one area that's developing. Lots of people trying lots of other things. I don't think there's good evidence yet of what really works and what doesn't. In tendons, there's again a lot of people doing lots of things. We know what doesn't work, I think, but some people are using steroids next to tendons. In some areas of the body, for example, the upper limb, I think that's very useful. But in the lower limb, we're now getting much more aware that we might cause problems, because steroid next to a tendon can cause the tendon to become weaker. It means the tendon doesn't regenerate as easily when you initially inject the steroid. So if you have an abnormal tendon, one that's not happy and it's inflamed, or indeed it's more of a degenerate process that's happening, you could increase the likelihood that that tendon might snap or break. So in lower limb tendons, we're trying not to use steroid, and we're trying to use lots of other therapies. Now, tendons are, what we know about them is as they get painful, they send in extra blood supply. So new vessels form around the tendon. And that's probably a good thing. But with that new blood comes pain fibres, and it's the pain that causes a problem, because people then can't do their rehabilitation, and they can't, the physical therapist gives them an exercise regime to do, and they can't do it because they're in so much pain. So what we're realising is some of these therapies are trying to break down some of those pain fibres and blood vessels, and they seem to be working just on that basis. So we're injecting what we call normal saline, which is like a salty water, but it's the same concentration as the blood, and we put that next to the tendon, in the tendon sheath, so the covering of the tendon, and that can break down these vessels. We might try and stimulate the tendon to regenerate. So by that, what we're doing is we're putting a needle actually through the tendon, a very tiny needle, but we put it through the tendon in several places, and that allows the tendon to bleed a little bit, and then some good factors from that blood come in and try and help repair the tendon. So that's one therapy. Sodium hyaluronate is being injected around the tendon, in the tendon sheath. Again, we think that's more of an anti-inflammatory thing rather than anything else, but in some patients that's working. And then there's another technique that people are using. They're taking blood from patients, and they're either using the whole blood that is taken from the patient, or they're taking it away and spinning it down in a centrifuge. So they then take different parts of the blood and they inject what they think is the best bit, the bit that has the growth factors in, that will help regenerate the tendon, and they're injecting that back into or next to the tendon that they're concerned about. The fact that there are so many, and there are more than I've mentioned, but those are the main ones of the moment, I think says we don't know yet which ones are going to be the best for which problem. And I think that's probably one of our biggest challenges, to know, perhaps in a few years' time, if a tendon looks like this on imaging, the patient tells you they've got this problem, whether that tendon will respond to which therapy. And that's, I think, quite an exciting area of development and research.
Definitely. And what are the latest interventional procedures in the area of radiology?
Well, in musculoskeletal, I think we touched on image guidance and you know, the fusion of technologies. I think what is quite exciting is being able to use ultrasound to guide injections into areas that we didn't think was possible, because we're now making it safer by the use of MRI and CT. So that must be one area. I think we're now appreciating that we can do a lot more through the skin rather than having to go to a big theatre situation, perhaps having a cut for certain procedures. I mean, because of my interest in sports medicine, most of my things are, as we've discussed, to do with injecting joints, injecting tendons. But I know in musculoskeletal there are people injecting cement, for example, into vertebral body fractures. That isn't done under ultrasound yet, but they're using fluoroscopy to do that. People are injecting various compounds next to nerves because, you know, they have the imaging now to do that. So fusion technology can be used to do that. But again, fluoroscopy is probably still being used, and CT on its own. So there are lots of things that are in development whereby we're taking over some of the domains that were done under a surgical technique. So making people have, you know, smaller scars, perhaps, you know, less likelihood of infection because they're not having to stay in hospital so long. They can come in, they can just have their procedure done and then go very quickly afterwards. So these, I think, are the main developments in interventional MSK.
Lastly, what message would you like to convey to our audience?
Well, I'd like to say that I think imaging is a very powerful tool, but we mustn't forget our clinical basis, and we must remember that examination and taking a good history from the patient are still very important. And correlating the imaging with what the patient is complaining of is probably the most important thing that we have to keep in mind all the time, because unless we do that, with all the technology we have in imaging, it's very easy to perhaps treat the image rather than the patient with the image. And as a radiologist of today, I think some of the newer radiologists, the younger radiologists, they don't have those clinical skills. So we do need to keep reminding them that they do need to have those clinical skills to make them safe and good professionals.
Okay. Thank you, madam. Thank you for spending your valuable time with us. It was a nice time with you.
Pleasure.
So that was Dr. Georgina Allen with us. Until we meet next time, this is me, Anjali, signing off. Take care.